Hello, hello everyone. How are you? Sorry for the delay. We have some technical problems at the beginning, but around we are ready to start. Hello everyone, and welcome to this DESS webinar. First of all, we will like to thank all the attendees, all the people that are interested in this webinar, to be here and participation in this session. We hope that you will enjoy. Okay, my name is David Cuervo. I'm part of the Technical Customer Support Department at DESS headquarters here in Barcelona, in Spain. And I'm also with Paul Cammani, it's manager of the DESS Marketing Department here in Barcelona as well. For today's webinar, we have the valuable collaboration of Dr. Brisman. He's a key opinion leader of DESS, and he's in his clinic office in New York right now, and from where he will presentation this lecture. Our idea is that today this is a collaborative webinar, so you will be able to ask anything that you consider. With Dr. Brisman and the DESS team, we are delighted to provide you with whatever feedback is needed. So in order to run everything smoothly, we structure this presentation in two groups. First of all, we will proceed with Dr. presentation. And at the end of them, there will be a question time where you will be able to ask freely. And in case that you want to leave a chat, it's activated, and then you can leave your questions there and will be answered at the end of the webinar. And last but not least, this webinar will be recorded, and then we grant to access it and be able to enjoy it whenever you want. So, Doctor, hello, how are you? Good afternoon, New York.
All right. Hi, David. How are you?
And fine, thanks.
So thank you very much. You know, what's exciting is we've done several webinars together, and this is actually our first one in the United States as relates to time zones. So it's a little late for you and Paul, and thank you so much for accommodating. And thank you, ladies and gentlemen, for your time. What I'd really like to do tonight is sort of just discuss my journey. And as David has mentioned, I'm a full-time practicing prosthodontist here in New York. And really, what's interesting is my journey led me to DESS. I actually found them, and that's really what I'd like to kind of show you is why did I find them, and what was important in the treatment for my patients that required me to come up with some alternatives that would help and enhance the treatments. So tonight's sort of conversation is the title would be DESS products within the dental clinic. So I sort of wear several different hats. Most of my time is at the dental chair doing clinical care. I also run an in-house dental laboratory. So I sort of have a unique perspective as relates to I manufacture, design, and fabricate the restorations that go in my patient's mouth. So I really understand things both on a laboratory side as well as on a dentist side. So I sort of bridge that gap between the manufacturer and the clinician. So really, we're going to kind of go over a few different cases of practical implementation of real cases that have been treated within my office. And really, in a nutshell, the question is, why DESS? Meaning, how did I come? And my journey is probably, I guess, David, maybe 5-6 years already. And currently, I serve as their chief clinical officer, and as David mentioned, their key opinion leader. So let's get to it. Really, we're going to kind of talk about 3 different points. We'll sort of start out with an introduction of perioprosthodontics. In other words, what has changed within the clinical practice of dentistry where we evolved from the tooth to now treating dental implants. And then we'll spend much of the time discussing what we're calling the post-surgical treatment planning, meaning once the implants are in, as restorative dentists, Now we really go to work. Why DESS? And we'll discuss the goals, how to implement those goals, what materials we use and why. And then at the end, I want to share some of the data over the past 4 years of what I have found using the DESS product line. So if we begin tonight with a sort of a dialogue, this is an upper first molar that has been deemed hopeless, promptly removed and bone grafted by our surgical colleagues, and then an implant is placed. So what's interesting is now really, as we are restorative dentists, this is where we go to work. So what we're looking at from the head of the fixture to the gingival margin, this transmucosal zone. John Zamzak and others discussed quite a while ago, 1996, his paper was presented at the Academy of Aesthetic Dentistry, where he talked about non-surgical sculpting. And what we're here as clinicians, we're used to seeing things super gingival, but now that we're getting involved in restoring dental implants, for the most part, it's supracrestal. And this red zone is really the focus because ultimately the patient wants to have a tooth that looks and feels like a tooth. So what we're really trying to do is create, in the case of a first molar, that trapezoidal root anatomy to the tooth. In this case, and which is many years ago already, it was done with a custom abutment, and that emergence profile was to create that trapezoidal zone. Again, you can see the fixture, so it's from the head of the fixture to the gingival margin. And ultimately, the tooth looked and felt like a tooth, but for the patient's perspective, they want to be able to function properly as relates to cleaning it and have it feel like a tooth. So with that as our introduction, let's sort of get into the concept of how, in fact, I met DESS and why I met DESS. So if we bring our patient, she was requiring, you'll see a full maxillary reconstruction, but I want to kind of zone in on this one quadrant. You can see the patient has tooth number 2, missing number 3 with a modest bony defect, missing number 4, 5, and 6 were deemed hopeless. So the patient elected to restore this with dental implants. And where do we start? So we always start with this pre-surgical treatment planning. And ultimately, with digital technology now, we want to do a cone beam and merge that to a CBCT with an STL. But ultimately, as restorative dentists, we need to dictate to our restorative colleagues, our surgical colleagues, what's our treatment plan? Meaning, what do we want? Do we want it to be cementable? Do we want it to be screw retained? Where do we want the screws to come out? What are we looking to do? What materials? For me, I really just have 2. In a simplest sense, I have 2 prosthetic treatment plans. One is, and we'll talk about it for a moment, I want the restoration to be screw retained. And 2, I want it to last. I want it to have integrity. I want it to fit and have it fit properly, but also to have it screw retained. So let's sort of talk about that. They're really sort of 2 camp. And what's interesting to note is that within implant dentistry, when we first really started out in the late 80s, everything was screw retained. And of course, the culture had changed and there was a little bit of a paradigm shift to cementable restorations to sort of parallel the crown and bridge analog. And now we're sort of going back to screw retained. So with screw retained, there's no cement. And Tom Wilson and many others have shown a positive relationship between excess cement and disease, the cement being cost, and it's retrievable. Juxtaposed to that, the camp of cementable, it's perhaps a little easier to do, and there's frame passivity, which is extremely important. Sheedy discussed the principles of screw retained versus cement, and what they found basically is it's more accurate to do a cementable restoration because you're not relying on it to intimately fit the entire restoration down onto the implant head. So my question is, can we get both? Can we actually have something screw retained yet harness the advantages of the cementable? Let's hold that in mind. So as we come to our patient here, again, we do some pre-surgical treatment planning. And from that, we create a surgical guide. So we've told our surgeons we want it screw retained, we want it to work, 3 or 4 implants, etc. So the question is, are we done? Are we finished? Meaning, as restorative dentists, have we done our work treatment planning wise? Well, not so fast. The story talked about the accuracy or perhaps the inaccuracy of guided surgery, not only in this case static guide, but in the dynamic guide. And what they found is clinicians are advised to maintain a safe distance of at least 2 millimeters. So I sort of understand that in the surgical world, but in the restorative world, perhaps 2 millimeters would be a difference between a cementable and a screw retain restoration. So let's get back to our patient. The implants are now in, and really what we have to do is kind of do things a second time, if you would. We need to acquire our data, design our case, and make our case, manufacture with different CAM softwares and milling strategies. So the first step in data acquisition is to record the implants. So we take off our healing abutments, and there's really 2 ways to do that. We can do that directly in the mouth, create a digital work, and we'll talk about that in just a second. But the important point here is right now, before you start, you have to determine who the restorative manufacturer is. Are you using all DESS components? Are you using first-party components, and why? So why do we need to do that? Well, this really kind of came to me and really sort of was the microcosm of why I created a universal system. So if you're going to do a digital intraoral scan, you would put the scan flags in the mouth and scan them. But the important part to note is there's 2 parts to a scan flag. There's the coronal part, which is specific to the manufacturer. So these are 2 scan flags for the same dental implant, the same manufacturer, same connection, size, and style, but 2 different restorative manufacturers. So what's important to really understand is you're going to have to figure that out before you actually make your impression. Your other option, of course, is you can make an analog impression and make a cast to that, and these can be scanned in the lab, which may in fact be a little easier if you're not so sure who your restorative manufacturer is. But let's continue on the journey. So the next step, of course, would be to design our case. Remember, my 2 prosthetic treatment plan points are I want the restoration to be screw retained, and I'd like it to last. So as we begin our design development, we really have to kind of start over. We have to do figure out where our implants are. Then we would create another diagnostic wax up. Remember, this is post-surgical at this point. And what's really interesting with the digital technology is we could really analyze the frame integrity. So you can actually measure in an area, square millimeters, of what your connection style is. Prior to this, in the laboratory analog world, we would just do a wax up and cut it back. And then the final thing is determine our screw access. So here we did guided surgery. Everything was planned as perfect as it could be. And my question is, how'd we do? Well, meaning, was I able to achieve my 2 goals? Well, certainly I felt pretty comfortable about the integrity, and I was able to measure the restoration or the connection of the zirconia, and it did meet manufacturing specifications. But what happened? Were we able to do screw retained dentistry? Probably not, because if you can see on the tooth number 6, it's coming out the incisal edge. And frankly, I'm not even that happy with tooth number 3 and 4. They're not really equidistant within the occlusal table, creating occlusal stability and not having the hole on maybe an outer incline. So my question is, what occurred? Well, it's actually a geometric problem, because if you measure from the head of the fixture to the occlusal table, and we'll call this from point A to point B, if the angle is off, just in this case, lowercase d. If the angle is off just a touch, the distance will be greater dependent on the distance from A to B. So meaning the angle is commensurate with how much further off it will be. So this distance now of distance D is exacerbated by that angle. So even if you're off a couple of degrees, by the time it exits on the occlusal or incisal table will really be the difference between screw retained and cementable dentistry. What's important to note is if there's a lot of volume loss, okay, if you're dealing with a lot of space from the fixture all the way up to the occlusal or incisal edge, that angle is even more applicable. So what are our solutions? What do we do at this point? And this is really what brought me to DESS, because what I wanted to do on multiple systems, on multiple implant connections, is very simply an angulated screw channel. So wouldn't it be great if I can just grab my design and pull this in exactly the spot that I want? Not only in tooth number 6, but in tooth 3 and 4. Wouldn't it be great not only for this case, but perhaps for every case with every implant and every kind of implant? So let's just talk for a minute about this angulated screw channel. Was this invented in dentistry? Actually not. So the patent in the United States was 1981, and this was a ball and socket. It's physics. So our engineers would tell us that certainly in mechanics and in auto mechanics, it's very prevalent. What's more interesting to note is one of the companies that sort of created this ball and socket was Camcar. Camcar in 1967 created what's called a torque key, T-O-R-X. And what a torque key is like a star, if you would. And it's really something that's important not only in mechanics, but in implant dentistry. So if you're going to use an angulated screwdriver, you want to make sure that it does have a torque design, because it won't slip out as fast, and that's measured in the cam out. Whereas a hex design is going to slip far further. You can see geometrically the torque design locks in. So within dentistry, that torque design is in the angulated screw. So what does our data show us? Well, it's very compelling. Greer discussed a paper in 2017 and found 96% of the time there were no mechanical complications with angulated screw channel. Swamidas, same thing. Angulated screw channels perform comparably with conventional straight line screws. It works. There are studies, if you look a little further, that talk about failure of angulated screw, but they only tested one manufacturer, and it was an all ceramic manufacturer. It did not have a tie base in it. It was not DESS. In our research, we can actually generate almost the same force of Newton centimeters up to 25 degrees. So this angulation, and we very rarely go all the way to 25 degrees, but you can. And if you're going to 15 or 5, you can get the full torque. But even at the highest grade, you're going to get 51 Newton centimeters compared to 60. Quite significant. Far more than is required to tighten it, which at most is 35. And what's really exciting is it's all there, meaning all the clinical screws are there for all the different or most of the different implant systems. And with the DESS products, we're able to actually see on the box what to tighten it to. And what you'll find is it's identical. The straight to the angulated screw is exactly the same. So with that in mind, our final part is actually the manufacturing. And if you can kind of get one point from this slide, I would say a mill is not a mill is not a mill. There's a wide variation in mills. And not only is there a wide variation in mills, but there's a wide variation in the software or the nesting software that runs. Some of the mills have proprietary nesting software and some have universal. And the strategies become very, very important. And what's important to sort of understand is this angulated screw is very important. Within the milling strategy, you can see the slide on the left. The driver goes fully within the tie base, whereas on the right, which is another tie base, it balloons out. So you got to create space for your driver. Why is that a problem? Well, the milling strategy needs to create space for that, and it might create a thinness, particularly in the labial surface of an anterior tooth. And if it doesn't meet manufacturing specifications, you can't mill it. The system actually won't allow you to mill. So in this particular case, which was done quite a few years ago, we did full veneering. You can see there's a copings or cutbacks throughout. We really don't do that too much anymore because the zirconia is multicolored now. It wasn't in these days, and it really allows a very, very nice aesthetic result. But after we veneer, again, clinically, we're able to idealize our screw access and finish our patient accordingly. So let's sort of delve into this transmucosa element. In other words, what is being used here? What did I use specifically to manufacture this bridge? So really, it looks like this. This is what the bridge looks like. But this is the part that's subgingival and supracrestal. And really, you can see the majority of it is in zirconia, and there's just a little bit of the tie base that is prefabricated. What are our choices with these transmucosa elements? Well, there's really sort of two camps. One is, as we know, we can make our restorations to an abutment level. So in this case, we can use multi-unit abutments, and we would put our restoration on top of that, but you still would, in fact, use a tie base, so it's really a double abutment. Or we can do the case down to the fixture level. And it really depends. There are advantages and disadvantages to both. The camp on the abutment side, it's a supragingival, which is a tremendous advantage. The abutments that you use generally are prefabricated. These multi-units or prefabricated abutments can be placed at the time of surgery or at the time of the restoration, and it really requires a second abutment. You can see here in the bridge, those are tie base or titanium bases or a second abutment. On the other side, which is more prevalent in the aesthetic zone, certainly, is making our restorations down to the implant level. And there's really not many choices here. We can do a custom abutment, which we've done for quite a while, but you can see here, and even from this slide, you can see the porosities involved in the analog casting mechanism. You can mill metal. We can mill it out of titanium and make custom abutments that way. You can also make customized tie bases. The problem with that, frankly, is you can't do it yourself. So you're going to have to send it to a third party, and you're really relying on their design and their manufacturing, and that is problematic in the lab. You really, as labs, your lab's going to want to be able to control it. You can see here, I'm not even crazy about that design. It's not the right cusp or intercuspation of the occlusion. So it seems that if we did it on our own, we can mill it all out of zirconia. The problems with that, frankly, is that you're putting zirconia into the implant, and what has been found is the implant is softer than the zirconia, and pieces of the zirconia will actually come off, or actually pieces of the titanium will rub onto the zirconia. So really sort of the best of both worlds, or the best of everything, is a hybrid. A titanium base milled to either zirconia or PMMA, or in limited applications, you can even mill it in lithium disilicate or Emax. There are many different types of tie bases on the market. Some are cementable, some are actually friction fit. But don't you think there's a need for one system? It's extremely difficult, if not impossible, as we'll see in today's aging population, patients coming with implants. The implants are still good, and it just requires some restorations, maybe additional implant. So you really have a potpourri of all different systems. and you're not going to be able to choose different systems in your design. You need one universal system. And that really is what led me to DESS several years back. People talk about the problem with cementing, which we'll talk in a moment. If you're going to use a friction fit tie base, there are limitations to it. So here's the same 231, and we designed it both on a friction fit as well on the right, which is the DESS. And what you find here is the milling blank on the friction fit, the softener won't allow you to bring the milling blank down, so there's a gap. And when you finish your restoration, it's like a lollipop, and you have to fill in that gap, which you can do, but it just creates another step, another level of complexity that is problematic. And then finally, let's talk that the idea of this two-piece system, and this brings to back the concept of a passively fitting frame. We talked initially, the advantage of cementable restorations is you can bring your bridge down, and if it's off just a little, it's still going to fit. You're not screwing the bridge down. But the problem with multiple units on screw retained is creating that passive fit. So the workaround for that is really understanding the system. So here you have the tie base. There's a little portion that engages the implant. It'll engage external in this case, internal hex or an external hex. And then there's the prefabricated portion, which is quite small. And you can see the majority is really up to the designer. And that emergence profile can be customized, which is very, very exciting, certainly in the anterior zone. Well, how do we attach these? In the multiple unit case, my recommendation is this. I try to create a non-engaging verification cast. So I would ask your doctors, if you're a lab or a reseller, if you're a dentist, my advice would be to bring that patient back for one visit and do a non-engaging, so bring non-engaging impression pieces and make this cast. Why do we do this? Really 3 reasons. There's milling inaccuracies, the implant alignment could be an issue, and the master cast discrepancy can be off even in the scan body case. It's nice to be able to create this, and what you can do is work out the implant malalignment. And when this is cemented, it's not cemented in your hand, but it's cemented on this verification cast. And this sort of parallels the concept of why back in the metal ceramic days, post-porcelain soldering became a thing, because you can seat your restorations and duplicate that exact position in the mouth. And that is very exciting. The one sort of a caveat to that is the single unit case. And of course, you're going to use an engaging tie base here. And in the DESS world, on the angulated tie base, what you have is you have a rounded tie base with a crease. And you can see here in the zirconia, the intaglio surface has a crease. So my recommendation here is not to do a cast. And the reason is the printed models, or even the master cast that you'd be making, there are inaccuracies. Here it broke. So my suggestion would be to do it in your hand under microscope. And that's in fact what we do. We magnify this and we locate that crease in the zirconia. Then we locate the crease in the tie base, and we really try to create equidistant spaces from the red to white on the left side to the white to red on the right side. And how we know this is DESS will even furnish you with library files, or in the 3Shape world, the DMEs of various gap versions. And the reason for this is the inaccuracies in the milling process. They have a 0.2 micron gap version as well as a 0.45. So really a lot will depend on the mill that you use. There are mills that are extremely accurate and ones perhaps that aren't as accurate. but you can see here, and I would say 100% of the time we do this in our lab under the microscope in our hand, and we're able, certainly in the single tooth case, you want to create that it slides in and you're doing very little of any interproximal reduction or modification. One workaround for this is when there is a parallelism issue, and the concept here is, and I don't quite know who coined the phrase screwmentable, but basically it's a custom abutment and a crown that has a hole in it. And the concept is, if you look at the implant restoration that is bordered on a tooth or a crown on either side, you're trying to parallel not only the contact areas, but the, in this case, the internal hex morphology of the implant. So in the design phase, what's exciting here is you can identify this, and there is a path of insertion problem. The implant is not placed, not parallel to the screw access, that we can correct, but the interproximal anatomy. So here, when we begin our design, we'll design our crown first, and then from that, what we can do is modify our abutment. And this is not an extra visit, because we can actually take this custom abutment, export the core file, and then manufacture the crown. So we can send our patients or our doctors back with the custom abutment and the crown all in one. And this is kind of what it looks like. So it's an angulated screw channel or the Orem base cemented under the microscope onto the custom abutment. And really what you're going to do is you'll cement it in the mouth and then pull out the crown afterwards, clean out the cement, and then screw and seal it back into place. So what's often asked is, can this sort of post-surgical treatment planning be done immediately? Meaning, can we do this immediately post-surgical or provisionalization? So our initial patient that I treated several years ago had an accident with her grandchild, which is kind of common. She said she got hit in the head by her toddler grandchild, and they knocked one tooth out. So I said, it's okay, let me just take a look. And sure enough, they did not lock one tooth out, but knocked all three out. So we went over a variety of treatment plans with the patient. Do you want to take all three teeth out, maybe to put 2 implants in and a 3-unit fixed partial denture? At the end of the day, she just wanted to do as little as possible. So in this case, it was removing only 1 tooth, number 8. But what's important to me is this. Again, I want to create that triangular shape of the tooth morphology. So really, it's the analog, as we discussed initially, of the periopros root anatomy to the implant restorations. So our tooth is taken out atraumatically. And what's exciting here is we'll scan this right at the time of surgery, and then within 5 minutes design a provisional, or in this case, we did a custom healing abutment. And what's exciting with this technology is we're able to create something from below. And what I mean here is we're identifying the head of the fixture, and really for the first time, I can actually look up. And what I mean by that, and you can see here we use the angulated screw channel, but now through the design process, this is really an aha moment, because I can look up and I can see from below. We spent our whole career, didn't we, looking down. And with the design of some of the digital technologies, we're able to do that. So we look at our extracted root. This is made out of PMA, takes about 5 minutes to mill. And here you have it. It's an angulated screw channel, the DESS angulated screw channel. It's made for virtually all the different implant systems. And we can put this into the mouth. And really what we're trying to do here is preserve the papilla. That's been shown certainly in the literature. Joe Kahn and others talked about why we take teeth out and place implants at the time of extraction and put either a provisional or custom healing abutment. Here, we utilized the 2 other teeth, and through the design process, we milled a PMMA provisional, cemented it into place. When the patient returned following healing, this is what she looked like. We worked on 7 and 9 restoratively. And my question is, how do we do? Were we able to keep that papilla? You know, I think we probably did pretty well. And this is really utilizing the technology that's available. And again, it's that triangular shape that we're trying to preserve, in this case of a central incisor. And then we duplicate that in zirconia and 3 individual units. But what you're looking at here is, again, the angulated screw channel, pretty much exactly where we wanted the exit placed. So some of the problems in some of the implant systems are this. Depending on how deep the implant is, and we have this on the DESS website now under our cases, but what you can see here is the high base at the time of surgery didn't go down all the way. So what happened? It is just a little too big mesiodistally. So I then modified the tie base to get it to seat. This is very common in the maxillary anterior lateral position as well as in the mandible, and it's because of the parabolic nature. The surgeon places the head of the fixture normally at the osseous crest at the mid-buccal point, and then even with bony profiling, it's very hard to get that tie base down. So what we have now is something called an elliptical tie base. So it's about 30% thinner mesiodistally. And what does this look like? Well, if we take this patient here, this particular patient is losing tooth number 10. And what's interesting here is he lost tooth number 10 about 3 or 4 years ago. And what we did at the time, again, and this slide is about 3 or 4 years old, is that's the hopeless number 10, and we did guided surgery. So we planned it. We made a guide. The tooth was atraumatically removed. The implant was placed. We scanned it. And then we fabricated an angulated screw channel PMMA, and the patient left. But what's interesting, as we seated this, again, I couldn't get it down all the way. Upon trying, the provision could not go completely. So what I had to do is modify this, which I did. So the question is, patient returns to us 3 years later. So what are our solutions? How do we deal with the final restoration? Well, we did a provisional at the time of surgery, so certainly we were able to get that triangular shape, but you can see how tight it is here. So do I remodify the titanium base or make a custom abutment that's screw retained? No. What we can do is we can actually scan it with our scanners, with our scan flags, and in the library catalog or the DMEs, we can choose elliptical tie base, and we can actually create the elliptical tie base here. Now, what you're looking at here, which is very exciting, is the lower slide, the lower provisional on the left is my original tie base, where this is before the elliptical tie bases were even available, and that's what I had to adjust. But even after I adjusted it, you can see how much thinner and leaner the elliptical tie bases are. So this is an exciting technology. It's coated with zirconia nitride, which we'll talk about in a second as well. What's interesting here, and sort of the next sort of point, is can we do this technology on a full arch case? So here we have a patient that has a terminal lower dentition. So historically, what we would do is we would do all on 4, all on 5, or really what we're saying here is a full arch immediate load reconstruction. We're going to extract the teeth, and at the time of extraction, place the implants, and then do a same-day conversion. So why do we do this? And should we do this? Well, what if we didn't do this? What if we did a day plus 1 provisional, meaning not do a same-day conversion? What are the advantages? Well, it's a shorter surgical visit. For me, I'm going to my surgeon's office, and I don't feel that comfortable without my office, but I'm doing the conversion in their office. Generally speaking, the patient's under some type of IV sedation. So if you did not do it, it's much less anesthesia, a much shorter visit. It's a very wet environment that we're working in on the same day conversions, a lot of moisture, contaminants. There's not much design time. We got to kind of move as fast as possible. And really, what if we chose not acrylic, but a PMMA? And what's that shown is that it's actually a better material. So if we mill PMMA as our provisional, there's less inflammation than a polished acrylic provisional. So how does this work? Really, we'll make just one impression at the time of surgery. And here we kept the teeth in just for intermaxillary records. Then the teeth were removed. And then we go to work. We pour a cast, scan the cast, and really that evening your lab can extract the teeth. And in this case, we went to multi-units. So we located the multi-unit abutments, and then we begin to design our case. And what you're looking at here, again, is angulated screw channels. But ladies and gentlemen, this angulated screw channel is to the abutment level. You have the same 25 degrees that you can rotate here. So you can see for the most part, I used all straight abutments. That's my straight multi-unit. And I was able to angulate my screw to exactly how I wanted it. And then we sort of put our pink into place. It gets milled in one color, and then we just color the pink, and this is what you're left with. These are angulated screw channels down to the multi-unit level. Patient comes back maybe a day or two later. We remove the healing caps, and this is at the time of insertion. So you're looking at a double abutment system here. So we simply, we're doing supragingival dentistry, we tighten this into place, and then the patient, after occlusion verification, leaves. And this is how they come back several months later. And really our work is done because we've already done our design, and we duplicate that, in this case, in zirconia. So let's, in the remaining time, let's sort of try to put this together. Let's compare our choices. On the DESS side, it's a third-party software, but what are the advantages of it? Let's compare that to the OEM or the first-party manufacturer. So on the OEM side, the issues there are design limitations. And what I mean by that is not all OEM product line is available. If you have some older implants, you might not be able to do a screw retain or an angulated screw channel. The OEM parts are just not there. They have limited products lines that are available and limited library files. And what this is really allows us to sort of pick and choose on a drop-down menu. A lot of the OEM don't allow local design, which is a problem for the labs. They don't allow local milling, which is a bigger problem. And the library files, what I mean here is it's sort of a drop-down, and you say, okay, this is my implant, and what's available? And there's a very limited library. It's just not always there. So what labs would do to sort of get around this, and I do not recommend this, is they say, no problem, I can give you the first party. So what they do is they'll put in a first party tie base, if you will, and scan it because the library files are not there. So what you're looking at on the left side is the same tooth number 6, where I scanned the first party versus where I used the library file. So the library file is the engineered arithmetic that is done to create the mill. And there's a tremendous amount of error on that scanned portion. So be very careful. I would highly recommend not using a scan first party, and always get something that has a library or a DME file that's available. Some of the other limitations are on the angulated screw channel. It's not 360 degrees. So here we sort of did this case twice. We restored the second bicuspid, both with first party and with third party. So you can see here the first party is on the left, the DESS is on the right. So on the first party, when we begin to design it, there's a timing issue. So the angulated screw channel has to be at a certain angle, and meaning you cannot fit your driver in, and this is in the posterior where you want it. It has to be in a very specific way. So you can see here, this angle only fit on one side. This is it. It's sort of a cutoff tie base, if you would. Yet on the DESS side, again, it's encompassed all within the housing of the tie base, the angulated screw channel. It's dramatically advantageous. So really, we can, in 360 degrees, take our time on a joystick, if you would, and create exactly where I want it. So dependent on the patient, if there's limited opening on the patient, it's not so easy to get that. So here you can see here, there's only a little window to put your driver in, whereas here you have 360 degrees up to 25-degree reangulation. So on the DESS side, it's universal to multiple systems and multiple connection type and multiple platforms. Local design is supported, local milling supported, and it's equal or perhaps enhanced componentry. What do I mean by that? Well, we talked about the elliptical base, not only the elliptical base, but what we're doing here now is we're coating this with zirconia nitride. So what is that? That's a coating that goes on the tie base that's 6 times harder than titanium. The surface is more resistant to corrosion. The biofilm will not form on that surface as easy. So what this shows us, and this is very, very exciting, is through the biochemistry, we can create these MMP8 values of the fluid. So peri-implant disease, as we know, that is something that we need to contend to all the time. And there are certain patients, just like periodontal disease, that are in fact more susceptible. So what's exciting here is we can actually pre-check our patients that are more susceptible perhaps to peri-implant disease. We really, really want to utilize these zirconia nitride coated things, tie bases. So let's sort of sum it up with the data. So if I look over, this is actually even a year old already, so now it's 5 years. But if we look at 4 years of my research, I basically treated 320 patients during those years, and I manufactured over 800 units of implants. Of the 320 patients, 317 were screw retained. So I achieved my goal the majority of the time. The only 3 patients that could not had implants placed where only first-party componentry was available. That's it. It was all proprietary. I only had 1 zirconia fraction in the lab over 4 years. I had 9 tie base decementations. So statistically, it's a very small amount. It's 1%. But what's interesting is it happened early on. And I think that it was user error on my part of really not understanding the tie base cementation protocol and which cements to use. And what I mean by that is you want to kind of parallel your cement to your zirconia. So the tie base doesn't quite matter. That's titanium. Your zirconia does matter. And you want to kind of unilateralize which zirconia you're using and which tie base. So if you're going to use, as an example, Ivoclar zirconia, you really want to use Ivoclar cement in the dental laboratory. We have 12 screw loosenings. I think that was probably, again, a low number, But again, user error. I hand tightened things in the beginning. I was nervous about stripping the screws, but I haven't had any strip screws, as you can see, no fractured or strip screws. So now I don't hand tighten them right at insertion. I'm going to the manufacturing specifications of a torque value. So if we look at this on the OEM side, what's interesting here is the number of patients and the number of units is close. And what that tells you is the manufacturer has very little componentry available on these large cases. So if we're going to begin to do our large cases, it's very difficult to do that on the OEM side. Comparing straight versus screw retained, again, an overwhelming majority of angulated screw channels. I use that irrespective of implant placement. Why would I not? I want to be able to, again, joystick that screw access, whether it's a posterior or an anterior case, to get it precisely where I want, whether I'm going down to the abutment level or, in fact, to the fixture. So where are we in 2023, almost 2024? These are the patients that we see. Patients are living longer. These are redos of reconstructions. Patients came in with many implants, perhaps too many implants. Some were new, some were old, custom abutments made, and wanted to have his reconstruction manufactured. So as we begin to take things off, what's available, you can see some of the trilobes here, and we wanted to connect it. Can we use angulated trilobes? Yes, we can in the DESS componentry. When we sort of designed our case, you can see the angles really are not advantageous. Really what we want is something like this. So we were in fact able on this multiple implant case to manufacture 3 bridges with all angulated screw channels, setting up pretty much where we wanted to go with very, very, very little exception. So in closing, we talked about that tooth to implant evolution in our introduction. We discussed the angulated screw channel, some of the technology of really taken from the engineering world and adapted to the dental world. That transmucosal element of the tie base, in this case, it's the angulated screw channel tie base. And then we looked at some of the data that we worked on over the past four years or so. So with that in mind, I think I'm pretty much on time, David, and not
yes,
share my
Doctor.
screen anymore, and perhaps try to answer any questions that
Yes.
are available.
Yes, Dr. Durin. First of all, thank you very much, as always, for your great presentation. Thank you. It's always interesting because you are adding some new cases. Just I would like to inform everyone that all the cases that Dr. Brisman presents today are available to check in our website, in our DESS website, the 3 cases, and we are planning to add more in the future. But right now, you want to check these ones with the specific information, you can check it in the website. Yeah, I have some questions. I would like to start with the last ones. Mr. Greg is asking about that you are using wobble extensions all the time.
Say that again?
Yeah, he said that you are using wobble extensions all the time. I think he's talking about angulated screw channels, screws. Okay.
Yeah.
And he said that maybe to scale all the most restorative screws is not possible.
So that's an excellent question. The reason I use angulated screw channel all the time is, I would say, number one, it actually makes life easy because it's one screwdriver. So what's important to understand is the angulated screw, the threads of it are different from implant to implant, but the top of the screw is identical. So the driver that you use is the same no matter what implant system you're using. It's one driver. It's an angulated screwdriver. So what I'll do with my patients that move away is I actually give them a driver tip, and I say, you know what, if anything should become problematic, many of my patients will perhaps move after getting their work done in the New York area. Maybe they move to Barcelona. I don't know. But I'll give them a screwdriver. But the important part here is, and this is important to understand, if you use a straight tie base, the screw is the same as the implant system.
That's
So
right.
what I mean by that is if you're going to use implant system A, implant system B, implant system C, you're going to need 3 screwdrivers. And if you use first party, you're going to need 3 screwdrivers. If you use an angulated screw channel, you're going to need 1 screwdriver. So for me, it becomes, obviously, I'll document it in the patient's record of what kind of tip I'm using, but I think using the angulated screw channel has a multitude of advantages, and I do try to use it virtually 100% of the time.
Okay, thanks, doctor. Yeah, just to reinforce your answer, it's true that in all our compatibilities, all the screws is following the pull switch concept, and then we use the same socket in all the screws that the original brand. But for angle solutions that are on base or elliptic base, we always use a Torx screw that doctor explained before in the technical question about how using this system. It's always better because you can apply all the torque in any 25 or 20 degrees angulation of elliptic base of Aron base. I guess that, Greg, you are glad with this question and this answer. And you have another one. It's a different question because it's related with all cases that are cemented and without any protective barrier, like such Teflon or cotton pellets, if it's possible to get the restorative screw without destroying the restoration.
It's a great question, and I'm asked that question a lot. So if you have a cementable restoration and there is a custom abutment underneath it, I would take off the cementable restoration first. So that's like removing any crown on a tooth. The general protocol is to create a slip up the axial surface, break the cement seal, and remove it. Then you're looking at the screw access directly. If it is one piece, then you have to create a large hole and try to identify it. The idea, the reason that you put tape in or cotton or polyvinyl, whatever material you try to, is precisely that. You want to make it easy should you have to get in there to do something. If the previous dentist didn't do that, then it becomes challenging to drill all of the composite resin down to identify the screw. It is very possible, and I do it quite often with cases that come in. My advice would be obviously to use magnification. I would also, of course, recommend illumination. And really, you're just going to drill down until you identify the screw. Once you do that, there's 2 parts of getting the composite out. One would be inside the screw, David, and the other thing to remember is the composite sort of forms on the outside of the screw. That you can chip off with a Cavitron or a scaler or an Explorer tip. So you use a drill to kind of get out the composite, but it is very possible to get it out. The disaster rescue, if you kind of will, would be to cut the restoration down all the way to the screw, identify the screw, and then pull it out that way. But you will get it out. You will get it out. It just takes a lot of time. My advice is if you think it's going to take half an hour, schedule an hour. If you think it's going to take an hour, schedule an hour and a half. It is very time consuming. Don't rush. Give yourself time. It's an excellent question. We all have had that problem.
Yeah, thanks, doctor. I have to say that I have some experience working in a lab and working in a dental clinic also. And when you have to destroy some restoration because you can access to the implant, it's always something sad. It's always something sad.
Yeah. Yeah.
Okay. I think that's all, doctor. If anyone have another questions? Now it's time because we're just arriving to the end of the presentation. In the meantime, I want to thanks again to all the attendees that will be present today. As you know, the session has been recorded, and then we will share it in case that anyone want to review or want to share with some colleagues.
Right.
I know
so pardon me, one point, David, I apologize.
Yeah,
for those in the United States, so there's sort of two websites. It's DESS USA and DESS Dental. What David's talking about is DESS Dental, and there's probably a link from one to the other. But what's important to really understand is on the DESS Dental side, that is where the cases are posted. And again, before you finish, I too would like to thank everyone for taking the time to spend time with us in the evening. We all had a long day. David and Paul, you had a longer day. But thank you.
Yeah, always glad to collaborate with you, doctor. Yeah. Finally, thanks again. I'm sorry, I have another question. That's the last time. Let me check. Is the Gen X screw we use with prototype cases to multi-unit abutments in immediate load iris restoration at the day of surgery? The head of the screw and seating tool is the same.
Say that one more time, David. So
yes, sorry.
A second screw, is it?
Yeah, is the Gen X screw we use with prototype cases to multi-unit abutments in immediate load iris restoration at the day of surgery. The head of the screw and seating tool is the same. I think it's a comment that Mr. Carl is giving his opinion about maybe his practice every day in the clinic.
Yeah, I don't know if I'm familiar with that screw type. There are many drivers that will go from platform to platform. An Omni driver will fit on an angulated desk, but if you're not using the right driver, you will tend to strip the screw. You really want to try your best to make sure that the screw is and steaming it beforehand is also another very important part, making sure all the debris is removed prior to insertion.
Okay. I want to say also to all attendees that in case that you have any further questions, you can share with support@dessdental.com, and then we can share it with doctor anytime. And you have some review of the webinar and you have any question, then you can share it anytime. Okay. Then thanks again, doctor. I want to say you that we have some people from United States, from Canada, South America, in Chile also. Thanks again. See you soon.
Thank you. See you soon. Thank you all again.
Yeah, thank you again for all the people that have been sharing this time with us. Thank you very much from this. And thank you for Paul and all the DESS team that is in this moment in the webinar. Thanks to everybody.
Thank you very much. It's always a pleasure. Take care of yourself.